Now me, the only thing they said about Brian Goldman is that he would study for a blood test. All right. Oh, this works. Good. Okay, so one of the things, I think that if you've listened, I did a TED Talk talking about my own mistakes, and I could go down that road, but to do something a little bit different, I want to talk a little bit about the culture of medicine and what I think is one of the common threads that makes it so difficult for us to, as healthcare providers, to listen. And it has to do with that little problem of empathy. And if you've lost your empathy mojo, I'll talk a little bit about why, some of the system issues, some of the technological issues, what the cost of that is, and what we can do about it through patient engagement and a couple of other things, some transparency, which is a very clear message that I'm hearing that people want to hear about. And try to wrap this up and leave plenty of time for everybody else. Now, Bill, I was told, well, we're going to have a serious day and we're going to hear some serious things. I hope that we can have, if not levity, then some satire. And I want to play, in a moment, I'll get our folks on the other side of the glass to turn on the video. I just want you to watch this. This is a wicked parody from a show called Little Britain. And it's a not uncommon kind of encounter between a mother and daughter and the first person that they meet in the hospital who's there to clerk them in, as it is. Have a listen.
The British pride themselves on being the rudest, most unhelpful people in the world. Receptionist Carol Beer is working at this hospital in Pennsylvania.
Hello. This is my daughter. She's a big, brave girl, and she's going to have an operation today.
Name?
Tell the nice lady your name.
Danielle.
Danielle what?
Danielle Lloyd.
Age?
Nearly 6.
You're 5.
Yes.
We'll say 5 then. Address? Where do you live?
With Mommy and Daddy.
1772 Lincoln Road.
We got there. Putting your details in now.
Danielle's going to have her tonsils removed.
I've got her down for a double hip replacement.
Oh, no, well, there must be some kind of mistake.
Computer says no.
Well, that must be some other Danielle Lloyd.
Computer says no. There's only one Danielle Lloyd on the system. Do you want the double hip replacement or not?
All right, I think we've heard enough of that. One of the things, now, of course, this is, you can say it's a parody, it's satire, but what's the definition of satire? The best definition I ever heard was a bitter pill with a sugar coating. And if I could, we could spend the next hour, the next day, dissecting what it was about that encounter. But right from the very first greeting or lack of greeting, how many of you find that you can go an entire day or an entire shift without smiling? Oh, come on. Come on. As if your smiles are revelations of inner turmoil, or they are, or they're, they cost $1,000 each. It's the cheapest, easiest thing that you can do. It's good for your health, and it will be good for your patient's health. You have no idea. When patients and families see you smile and look like you've got all the time in the world, even if you don't, it can make a huge difference. Now, that story was the satire. I'm going to play some real tape now. I had the extraordinary opportunity to watch the fledgling patient engagement program at Kingston General Hospital. And what you have there is a group it's an interdisciplinary group. You've got Chris Simpson over there, who's now the president of the CMA. You've also got a whole group of patients and families. All of these people have one thing in common. They all work for free at the hospital as patient experience advisors. They are all former patients, former family members of patients, or family members of former patients, and they all have a common denominator. They all came to the table with stories to tell. And I want you to hear the first one from Ellen Batter, who's a patient experience advisor, has been now for 4 years. She's on the emergency subcommittee. She is the spouse of a man with Alzheimer's disease and described the experience of being that family member every time she registered her husband who needed medical care. Let's hear that tape.
I was amazed at the lack of communication in the emergency department. By the time my husband, on one occasion, by the time we were in and out of there, I had to inform 7 people that he had dementia. The message never got passed on, and I had to talk about his dementia in front of him. It was very demeaning. I think I just had the general feeling that we were dismissed, and that you have a special connection with your spouse when your spouse has a dementia, and you don't want to speak for them, but you need to supplement that, and so I was never spoken to. It was just not pleasant.
And this is not the story of a disaster. So you don't have to have a disaster or a series of horrible medical errors, and some of the things that you're going to hear about fall into that category. It can be as simple as not receiving empathy. Inefficient systems that seem more in service of the people who are running the system than the people they serve. One of the most articulate patient experience advisors I met there was Jennifer D. Jennifer D. Has had many experiences in the healthcare system, but she's going to describe one in which she was a patient who had just received a double knee replacement for osteoarthritis. Go ahead.
A lot of the people around the table initially at the advisory council did not experience that, and I have a multitude of experiences to speak about that are negative, but I'll just pick one. As a non-ambulatory patient on an orthopedic ward, I was in a bed. I was dependent on the people at the nursing station for every single thing that I would get throughout the day and the night.
You had a couple of knees replaced, didn't you?
Good guess, Dr. Goldman. So I rang the buzzer, and of course I was on IV and getting lots of fluids. They were coming in, and surprise, they were also going out. I said I need to use a bedpan. The nurse brought me a bedpan and left me. She came back about 20 minutes later, and I said, "I'm sorry, it's very full. You might want to use 2 hands." She said to me, "I know what I'm doing." She yanked it out, dumped it in the entire contents in my bed, grabbed some blue pads that I know that you're familiar with, stuck them under me, and I stayed there for the remainder of the night while they had a birthday party at the nursing station. I'm not shy, and I'm not retiring. I'm reasonably well-spoken. What would someone with less capacity do? And I was dependent on her for all my pain meds. Do you honestly think that I would complain to her when my pain was already not being controlled? Where was my voice? I couldn't exercise my voice. I had no one to advocate for me.
And she wonders who would advocate for someone who couldn't advocate for themselves, which is something we've already heard. So, I can talk about a lot of problems, but I want to focus on what I think is the root problem, and that is a gap in empathy. And that's I don't know if I have a definition. I don't have it here. I mean, there are many definitions that I've heard: sympathy, feeling the same thing that somebody is feeling, or expressing sympathy, somebody who expresses sympathy. Sometimes I've heard sympathy described as empathy or sympathy for a person who is in a deep pit of despair. And the person who's expressing sympathy is at the top, at the edge, looking down and saying, I'm sorry for your loss, or I'm sorry for your, for your situation. Whereas empathy is the ability to put yourself in the place of the person with whom you're empathizing. And the metaphor would be, instead of standing at the top of the pit looking down, and expressing, nice thoughts, you're actually standing right beside the person in the pit saying, I know how tough it's going to be to get out of this because I've been there. And, maybe on your better days, maybe we can do that together. Or maybe I can help you. I don't think there's a lot of either, but there's a lot more of I'm sorry for your loss than this ability to put yourself in the position, in the place of your patient. And I want to talk for a few moments about some of the roots of that. I mean, certainly a lot of us in healthcare believe that empathy is a personality trait. And in other words, you either have it or you don't. I'm not an empathetic sort of guy. And actually that's not correct. And I'll present a little bit of evidence later to show you that we're hardwired to empathize. We all empathize. But culture and training trains it out of us. I think that a lot of us in healthcare these days tend to fear that if we become empathetic, if we demonstrate empathy, that a 5 or 8 or a 10-minute appointment is going to spiral into 35 or 40 minutes and that there'll be an insatiable demand. Once you're empathetic, you need to be empathetic all the time. How can I live up to that ideal? I think that the root cause for many of us is that we haven't received training. We don't know how to empathize. We don't know how to give an empathic response, and simply because we haven't been taught. I also believe in the culture of medicine that some of us believe empathy is a soft skill, something that you offer when your diagnostic skills are lacking. Be an empathetic person so when you make mistakes you won't get sued, I think. Why is it that family doctors are less likely to get sued than specialists? And if you listen on the ground of the culture of medicine, that's the kind of thing that you hear. There are other reasons. There's no question to me that technology is a double-edged sword. Technology is a wonderful thing. If you think of the ability to use technology to gather information quickly that would have taken weeks to gather or even months to gather in the past, and many, many trips to the library. Best practices can be shared almost immediately. You might actually end up with legible clinic notes. But there are other things that are part and parcel of technology that I think could be getting in the way of empathy. One of them is that infernal screen in the clinic. And how much time does the healthcare provider spend looking at the screen instead of listening to the patient? And I would also say, cut them some slack. How much time do they have to spend in front of that screen because the system demands that they follow rules, that they do things in a counterintuitive way to enter data in a way that is actually so much more difficult than it used to be with paper and pencil or paper and pen. And yet we are slaves to that technology. We are slaves to the latest software, and I can't tell you how often it happens, and there's a message in that the system is not particularly empathetic to healthcare professionals. So is it surprising that at times they're not that empathetic to patients and families? System factors. Back in 1984, when I started working at Mount Sinai Hospital, we saw 70 patients a day. I think there were 3 shifts. 7 a.m. to 3, 3 to 11, 11 to 7. Weekends, there were 2 shifts, 7 a.m. to 7 p.m., 7 p.m. to 7 a.m. Today, closing in on 70,000 patients. We have quadruple coverage now in many, many times in the day. We have patients who are older, who are more complex, who have more needs. There are more expectations. Social media, mainstream media is constantly talking about how we're overpaid, and now they're starting to talk a lot about the mistakes that we make. We're all suffering from what economists call productivity pressure, and I need to nod to that as well. Productivity pressure meaning we're constantly being asked through the use of technology, through patient volume, through patient complexity, to do more as quickly as possible. And that gives us an almost constant sense of time pressure that I think often reflects on the way that we are with patients. And I want to say a little bit about this. I said this on a column last week. Where did we get the idea that a 10-minute appointment is enough? Where did that come from? It kind of evolved. It evolved from the fee schedule, whether it's fee for service, and I know that many provinces, most provinces are doing their best to do away with fee for service. And the idea that healthcare providers don't get paid to innovate, don't get paid to do something creative, to do something different. And what I took from Pierre's story, for instance, was finding ways to go around the system. Well, the system doesn't reward people who do that enough. And one of the things you're going to have to get your brains around if you want to make the Imagine project really take off is to find ways of knowing when to standardize and when to customize. And to break some of those rules that get in the way of customization in favor of standardization. As a result, though, we figure out ways of making a living, whether it's fee-for-service or capitation or alternative funding plans. We figure out what we get paid for, what we can legitimately get paid for, and what we can't get paid for, and that becomes our work. It defines our work. And it's not surprising in whatever system you have in a world of productivity pressure that whether it's fee-for-service or AFP or whatever, that to keep things moving, we have to have 10-minute appointments. And so every time that a patient takes 5 minutes longer, somebody else has to take 5 minutes less, or you keep everybody waiting for 3 hours, and that's the reason why that happens. I think there's another thing that's going on here with standardization and guidelines. Who needs to take a history when a scan will do? And I think there's a lot of that towards the end of the 10 minutes or 12 minutes or 8 minutes. What am I going to do to get the patient out of here? And one of the things that we adopt as a strategy without even thinking about it is testing. We do a lot of testing, over-diagnosis, and often we find the right thing, sometimes out of luck, sometimes we find things we shouldn't find, because if we begin to work up an incidentaloma, we're going to end up taking a patient down a path towards more harm than good. We can talk about how empathetic we are to patients, but I ask you, how empathetic are we to each other? This is, I wrote a book, The Secret Language of Doctors, and I went to some places where they refer to M&M, morbidity and mortality rounds, as jousting. Now, I'm sure it doesn't happen here. I'm sure that M&M rounds here are affirmative, they're positive. People volunteer to describe their worst cases because they know that they're going to be treated really well, unlike other provinces, other hospitals in other provinces where that isn't the case. Anyway, how can we be empathetic to our patients if we're not empathetic to each other? I ask you. And I've seen too many people who have that split where they're really nice to patients and really nasty to each other. Whether it's competitiveness or whether it is one-upmanship or pushing people's insecure buttons, making sure in every verbal conversation, every interaction between referring physician and consultant, that everybody knows who's top dog in the power differential. Why do we do that? Well, as one anesthesiologist said to me in my book, when your last exam was 30 years ago, and everybody knows who won the gold medal and who won the silver medal, how do you compete? Well, you either compete with prestige or power or money. Take your pick. So my point is, we're not particularly empathetic to each other. What's the cost? The cost of this lack of empathy to our patients is errors and bad outcomes. Because if you're not empathetic, there's a good chance you're going to leave the hospital because you're dead tired. And even though that still small voice is saying, I got to go back and check that lab result, you won't, because you're exhausted. You'll be emotionally exhausted. You'll suffer from compassion fatigue, which is the phenomenon of no longer being able to respond in the moment emotionally to a patient's distress for a whole bunch of reasons, one of which is that maybe you've heard this story 300 times, and maybe you haven't vented your own feelings about it. Moral distress. You end up practicing in a way that goes against everything, every fiber of your being, everything in your heart that says this is just the wrong way, but you have to keep doing it because the system demands it. And so you suffer from burnout. And to our patients, errors and bad outcomes. Good news. Newborns are hardwired to display empathy. Newborns cry when other newborns cry. Newborns display signs of distress when their parents are crying and not anybody else's parents. So they're hardwired, like I'm not them. Like we don't come from them. We are hardwired to be empathetic. I'll give you another tip. Empathy is very good for healthcare practitioners' health. Higgins did a study. Medical students trained in empathic responses showed more compassion in patient interactions, and their stress levels during these encounters decreased. So it's good for us. I miss this guy, Rob Buckman. Dr. Rob Buckman, who was a comedy writer and a physician, a brilliant oncologist, who moved to Canada and then made a name for himself writing books and giving speeches everywhere about how to break bad news and how to be empathetic. And he taught me how to be empathetic in the most horrible situation of all in the emergency department, which is when you're telling a loved one the shocking news that will change their life forever, that their loved one has died. And he taught me. And he taught me by simply reminding me that it doesn't matter the words you use. What you do is give the person you're giving the news to the space to feel what they feel, to say what they say, and acknowledge what they're feeling. And I had a situation in which I was with a woman who was grieving the sudden, tragic, unexpected death of her husband, who she had spoken to 2 hours before. He said he had a little indigestion, and it turned out that it was a heart attack. It was an ACS. And he was brought to our emergency department in cardiac arrest, and we worked on him for a long time, and we weren't able to revive him. And eventually the code was called. It wasn't, I wasn't the lead physician. It was my colleague. He did the right thing because it was too late. And then about 2 hours later, his wife was brought in, accompanied by 2 burly police officers. And you know, there's a code in emergency medicine and probably in other parts of the hospital that you pronounce, you tell the family. And I remember following the 2 police officers accompanying the woman to the cubicle in the resuscitation room where his body was. And then I asked my colleague, do you want me to be there with you? And he said, no, I can handle it. Code. I do it. And I remember the sliding doors closing and the screams starting. And I went to do some other business, and when I came back, one of the nurses said, Brian, can you go in there? We can't reach the wife. She's just in another space. And when I found her, she was shaking her husband's lifeless body, trying to wake him up. And I remember, I tried, the acknowledging comments, hard to believe, difficult to believe, this must be horrible. And I wasn't even reaching her. And I wondered, how was I going to be able to do that? And then suddenly I could feel Rob Buckman on my shoulder urging me to just acknowledge what she was doing. Well, what was she doing? She was trying to wake her husband. And so instead of getting past that, because it just seems so weird to all of us and we need to move on, and she wants this moment to last forever because the next moment is just far too terrible for her to comprehend. And so I started to say haltingly, you keep shaking your husband to try to wake him up. And it felt right. You keep shaking him to try to wake him up, but you can't, I said, because he's dead. And the spell broke. She said, it was the most innocuous thing. She said, I've got to go to the bathroom. And she did. And I've been in these rooms where people won't even sit down. They're just pacing around the room as you're telling them this news because they feel as if they sit down, it's game over. This person really is dead. And you need to be able to understand that it's not about us. Well, why do we find it so difficult to do that? Well, it is hard. It's heart-wrenching. It's difficult. But there's another reason why. We keep involving ourselves in what the patient and their family is going through. We're defensive. We're afraid we're going to be accused of not doing our best or making mistakes. And we let that defensiveness get in the way when it's all about the patient and their family at that moment in time. And if you know that, if you understand that, maybe you'll be a little less defensive the next time you're in a difficult encounter. We're also here to talk about this. Patient engagement is something that Kingston General Hospital decided they had to do. And I'll let you hear Leslie Thompson in just a moment, the brilliant CEO of that hospital, talk about why. What they do there could be a model for what you're going to do here. They have patient and family advisors, former patients, family members of former patients, people with stories to tell, patient experience advisors, people who can say, I know what it's like because I've been through it. And they serve on every major committee in the hospital, no exceptions. They even sit in on interviews for new hires, asking questions because they're part of the hiring committee. If a new building is going to be built, they're brought in. If they're going to change the menu for patients or in the cafeteria, they're brought in. They also are beginning to deal with having conferences to debrief after major incidents. But as you can see, there's plenty of mundane stuff to keep patient experience advisors busy for a long time. Some of the things that they have accomplished, well, their credo. You've heard this before, nothing about us without us. Why? Because if I'm doing rounds with the family, if I do it in a cubicle or in the bunker or in a back room, there's a good chance that I'm going to miss some important piece of information. Whereas if I do it in front of the patient, or if nurses hand over to one another in front of the patient instead of in a back room, there's a good chance that there'll be a family member there who can correct some vitally incorrect piece of information. That's something that was brought about through patient experience advisors and through patient engagements. This is a small thing, but small things make a big difference. Daryl Bell is their point man, chaplain, but also point person on patient engagement at Kingston General Hospital. The patient experience advisors said, we can't read your name tags, change them. And they did. Big focus on the first name, photograph, and big letters, what they do. Because very often, patients will say, and family members will say, people are going in and out, and I have no idea who's who. A lot of hospitals are experimenting with high-tech gizmos to monitor how often people like me wash our hands. They went low-tech. They simply said, post a sign at the beginning, at the entrance to each ward, saying what the hand washing rate is. Their hand washing rates were 30-40%. They went up immediately to 90-95% and have stayed there ever since. Here's another example of patient-centered initiatives that isn't being done at Kingston General, but could be done there, could be done anywhere. I know it's being done here in Alberta, posting ER wait times. And in the culture of medicine, I have had lots of smart emergency physicians who've said to me, Brian, you're an idiot for talking about this. Because it's garbage in, garbage out, and you're only going to get somebody who's having chest pain from a heart attack to go across town to the hospital with the quickest wait time when they should be going to the nearest hospital, as if you can't educate people to do that. Yeah, they have legitimate beefs about this kind of initiative, but my point is, they're missing the point. And that is, fundamentally, posting an ER wait time, or any wait time for that matter, is all about saying, I care about you. I care how long you're waiting. I'm going to update you as much as I can in a regular way and not make it seem as if I'm doing you a big favor in the process. I said I was going to let you hear Leslie Thompson. And I want you to hear a couple of minutes of her because you need to know why they did it. Where were they coming from that made them want to make this journey that you're about to embark on now? Let's hear that clip. Oh no, got to go back. There you go. There it is. You got it.
I can think of at least 3 examples where the experience that the people had with our hospital was so difficult. It was so horrible that it took a long time for them to believe that we were serious about wanting their input, and some of those individuals have made the most profound differences. Our infection rates were terrible. 34%. It's appalling.
It was.
The way it was.
Yeah.
We are now consistently like 97% across all categories of staff, and we've sustained that for the past 2 years. One of the reasons why that shift happened was working with our patient experience advisors to think about the why, bring it really visible. So you walk onto every unit, there's a big sign that posts the hand washing stats. That was their idea. Equipping patients with being able to ask with more comfort, please wash your hands. They came up with ideas about how to move this forward that we just wouldn't have done on our own. So we made a declaration that any decision in our hospital where there would be a meaningful or material impact on the experience of patients, a patient would be at the table. I remember standing up there and going, I have no idea how we're going to do this, but I know it's important. So let's figure it out. And now we've got people at tables they never were at before. They're part of the decision making and the problem solving before we come up with a brilliant idea. It's very important that it's kept real. There should be a tension that exists to keep it all authentic. If the patients ever start to be the real cheerleaders for the hospital and take on that role as opposed to the sober second thought, it's like being an executive in any committee. If you start to hear everybody agreeing with you, you know you don't have the right people at the table or you're missing something. They need to be free. And if a patient feels like they're being held up as a poster child for a look at the hospital, how great they are, or as a, something that the CEO can tick off their list of saying, look at me, I'm great, it'll be over. I remember members of our board, our staff, and the community listening to some of the things that were being said. It was really tough. And it's on video. It was being essentially broadcast out. And
they said difficult things about the hospital.
Oh my God.
Yeah.
They talked about where we let them down. They talked about what it felt like to be let down. And where we didn't meet their expectations, where it hurt them and their family physically and emotionally. Remember someone saying, well, this isn't what you do as a hospital. You should be leaving the foundation. Why are you doing this? People won't give you money, or this is not good for the reputation. I said, this is everything about our reputation.
Greetings from Leslie Thompson through the magic of Twitter. Alberta's effort to jumpstart patient engagement, terrific. Patients as partners equals the only way. So she's right here with you today in spirit. Couple of other things before I close. You can't have patient engagement without transparency. That's the Trivago guy who everybody seems to like to lampoon on YouTube and on the internet. But my point is comparison shopping for a trip, a car, insurance policy is easy. Comparison shopping for doctors and hospitals is almost impossible. And I know Kai is starting that conversation, but we are nowhere near where they are in the UK, where they had the mid-staff scandal, where as many as 1,200 people died as a result of widespread negligence at Stafford Hospital, run by the NHS. It led to a public inquiry. It led to an extraordinary apology by the Prime Minister, David Cameron, the day the report was handed to the British government. It also led to the creation of something called a whistleblower-in-chief. This is a government inspector called the whistleblower-in-chief who systematically investigates hospitals proactively. And they are changing that culture that discourages medical whistleblowers, but it's easier said than done. Now they're moving on to transparency. So in 2014, UK surgeons must post their operative mortality rates or face sanctions. Now, the surgeons in the room are saying, Brian, I'm going to have a higher complication rate if I take the toughest patients. And that's true. And that has to be built into the metrics. But it doesn't mean that we shouldn't attempt to be transparent. And Kai is starting that conversation. We got a long way to go on that. The old way was that. The new way is doctor shut up and listen, and there are programs, healthcare professional communication training program in Harrisburg, Pennsylvania, standardized patient encounters, physician coach observes actual encounters, not for students, this is for people in practice like me. The result is a 40 percentile point improvement in patient satisfaction scores. They leapfrogged over 40% of the hospitals in America. Pretty amazing. Slow down. This is a wonderful book by Victoria Sweet, God's Hotel. It's called Slow Medicine. It just means slow the heck down. I don't need to say much more about it. Remember that, and I want to nod to this because I had a little bit of a conversation about narrative medicine, the power of story. Narrative medicine is medicine that combines clinical competence with narrative competence, the ability to bond to patients by understanding the complex narrative situations among doctors, patients, and colleagues, and their patients. And how that's what makes every patient unique. And we have Rita Sharon to thank, an internist at Columbia in New York City, who is the doyenne, the English PhD and internist, who was the first person to bring narrative medicine onto the curriculum at many, many medical schools, including here, the University of Toronto, Dalhousie, etc. I guess the dental students weren't part of that. I'm out of time. Last photo. I promised that I would leave most of the emotional punch to what will follow, what has preceded and what will follow, and I'm going to obey that. It's a shame that we have to become sick as patients to understand what it's like to be patients. I can also say by corollary, it's a shame that we have to experience the healthcare system from the other side of the gurney by being the loved one of parents who were ill and certainly lived up to that old truism that they spend more money on the last 2 years of your life than they do in all the years in between. But I would not be up here talking to you if I couldn't honor the memory of my parents who both passed away in the last 16 months, who were, as they say, avid consumers of healthcare services. They had some experiences that were awful. They had some experiences that were wonderful, in particular the last hours of my mother's life this past September 30th. It's a shame that we have to experience it from that side to know what it's like. It would be nice if there was another way. But I can say this, if you do have an experience, for God's sakes, remember it, use it, because it will help make you better at what you do, and no one will lose. Thank you.